The following podcast is part of a certified educational activity titled Innovative Approaches in Prostate Cancer, Bridging Genomics and Patient-Centric Treatment. Access the entire activity and complete the post-test at peerview.com/BQU860. Downloadable slides and practice aids are also available.
So welcome everyone, and thank you for getting up and being here for this symposium where we'd like to cover some innovative approaches in prostate cancer and try to bring bridging genomics and patient-centric treatment. Obviously, in 1 hour, we will not be able to cover the extraordinary amount of new data that's come out and all the options that we now have to offer patients with advanced prostate cancer. But we will do our best to at least give you a snapshot and hopefully get you interested in going and getting more information. So today's panelist, myself, Fred Sad, I'm professor and chairman of surgery at the University of Montreal. And I have Stephen Friedland and Tian Zhang that are going to be sharing the stage to discuss several options. So the goals for today are pretty ambitious. We'd like to go through the clinical evidence and the indications to support the use of systemic treatment, intensification for the management of advanced prostate cancer, and I would change the word intensification to optimization. I think we have to get beyond what is intensification. We are in this era where we want to optimize treatment, and that is usually by doing a better job of combining therapies. We want to go through biomarker assessment and how to help guide treatment selection to maximize patient outcome, and really focus on a team-based approach to really make the biggest difference for our patients to get the best, most effective, timely treatment in patients, unfortunately, unlikely to be cured of their disease. And the shared decision-making part, we just a shout out to ZERO for their involvement in really helping to support patient education, empower patients, and try to help us as clinicians being able to address all the questions that patients come in with. And thank you to the internet for making our lives miserable. Patients are overly informed and come in asking for the drug that cured that one mouse in a clinical trial. So these are things we have to deal with. That's the reality today. So without any further ado, I'll hand it over to my colleague Stephen Friedland, who's professor of urology at Cedars-Sinai Medical Center, and he's going to talk about high-risk localized disease.
Great, thanks so much, Fred, and it's great to be here. Appreciate everyone getting up early, and let's jump into this. So we have data now going back 20 years and even before then that actually have looked at patients who had biochemical recurrence, so PSA came back after surgery or radiation, helping to identify those who are most likely to progress and ultimately die of their cancer. And so this is a paper that looked at the natural history from patients treated at Hopkins. Very few got salvage radiation, and hormones by and large were delayed until the time of metastatic disease. Not necessarily what we would do today, but what you can see is if you have a doubling time less than 3 months or 3 to 9 months, those patients are extremely high risk of ultimately dying from prostate cancer. And you can put this together with other variables, Gleason score, early versus late recurrence, a little bit more granularity in the doubling time, and really come up with tables. And this is the likelihood of dying of prostate cancer with a really conservative approach. Again, limited radiation, delayed hormonal therapy, and we see in the low-risk patients, long doubling time, low Gleason scores, took a long time to recur, those patients do really, really well. And so I think that approach of don't need treatment intensification per Fred, it's optimization is the way to go. But for those who are in the red boxes, the question is, they're likely to die of their cancer, can we do something about it? And that led to the phase 3 EMBARK trial, and basically took patients defined by those criteria, doubling time less than 9 months, PSAs had to be above certain thresholds, and conventional imaging negative, which was the state of the art when the trial started in 2014. And we actually now know many of these patients actually would be PSMA positive, but they were enrolled in this trial, randomized to what we colloquially call a doublet, so to speak, enzalutamide plus ADT versus placebo plus ADT in a double-blind fashion. And then actually for the first time ever in a phase 3 trial, we said, wow, this enzalutamide looks like a pretty good drug. Maybe we don't even need ADT. Can we do enzalutamide monotherapy? Patients were treated for approximately 9 months. PSA was measured, and if the PSA was less than 0.2, treatment was stopped, and then reinitiated for this back on this originally assigned treatment arm when the PSA hit certain thresholds. And the primary outcome was metastasis or death, both of those being bad things that we want to avoid happening with our patients. And what we can see is both enzalutamide plus ADT on the left, as well as enzalutamide monotherapy on the right. Both of them were statistically significant and clinically significant delays of metastasis or death, which led to their FDA approval in November of 2023 for patients with high-risk biochemical recurrence who are no longer candidates for further pelvic therapy, and the inclusion in NCCN and other guidelines as well. And so just recently, we had the opportunity to update this now with about 2 additional years of follow-up, looking at overall survival and really seeing a really remarkable, unprecedented survival benefit from starting this intensified optimum treatment for these patients at this really early stage, even before conventional imaging metastasis, with a reduction in the risk of death by over 40%. Really, again, unprecedented survival benefit in a phase 3 global trial. And unfortunately, I would say, monotherapy did not reach statistical significance. And though the hazard ratio is below 1 at 0.83, there was no significant survival advantage to monotherapy. We did delay metastasis or death. It hit many other secondary outcomes, better preserve sexual activity. So I do think there is a role, but is not going to prolong survival relative to ADT, which is an active treatment arm. And obviously these are associated with certain side effects, hot flashes. We see, the way I think about this, I think to take a big picture view, is ADT has a certain side effect profile that we know. We've been using ADT for decades now. And ADT plus enzalutamide is just better ADT. It further blocks androgen receptor. And so any side effect from ADT, you're going to see more with ADT plus enzalutamide. And that's exactly what we saw. And monotherapy being a little bit different because you're not castrate. Testosterone does not go down to very low levels. It actually goes up, which gets aromatized to estrogen. And so what that estrogen can do is it can reduce your hot flashes, but can give you breast tenderness and gynecomastia, which we think is preventable with radiation to the breasts and or tamoxifen. So there are other trials in this space. They have not yet read out, and so we are still waiting. One is ARISTEP, which is a similar trial, but it's selected to be PSMA PET positive. So a similar biochemical recurrence, conventional imaging negative, used a doubling time criteria of 12 months, and patients are randomized to ADT plus minus darolutamide, and the primary outcome is radiographic progression-free survival by PSMA. So this is in that molecular imaging oligometastatic space, which is where the majority of EMBARK patients were. We just didn't necessarily know it at the time EMBARK started. And again, we're eagerly awaiting the results of this study. So, but one of the factors that we found is despite all these trials selecting based upon PSA doubling time, we've known the prognostic value of PSA doubling time for decades now is not always recorded in patients' chart. So we did a chart review where we looked at patients and we asked the physician treating the patient, what was the patient's doubling time? Simple question. Just tell us in a case report form, what is the patient's doubling time? And amazingly, 2/3 of the time, the physician said, I don't know. I don't know this patient's doubling time. And yet all the PSA values were there. We could go back after the fact with a calculator and calculate the doubling time. Physician said, I don't know. And when they said, I don't know, on the left, they were less likely to treat aggressively. For these patients who all had high-risk biochemical recurrence that we know are likely to die of their disease, and yet simply by not knowing they had this short doubling time, they got less aggressive treatment. And then when they did know the doubling time, they often overestimated it, i.e. they thought the doubling time was longer than it actually was in those we could calculate it, which kind of underestimates how aggressive the disease is. So that's on the right side. So there's still a lot of real-world logistics that we still have to figure out how to implement PSA doubling time, despite knowing for a long time it's clearly very prognostic. So where are we going in terms of the future? So we know in the metastatic space, clearly ADT plus androgen receptor pathway inhibitors have significant benefits. We've now seen it in high-risk biochemical recurrence. How about one step earlier? How about the time of initial diagnosis with initial treatment? And this was the ENZARAD study. It was recently presented at ESMO just about a month ago, and this was high-risk localized patients. Not the super high risk that we know from STAMPEDE has a survival benefit with 2 years of abiraterone, but again, one step earlier, trying to understand where can we identify a group of patients that has bad enough disease that they're going to benefit from treatment intensification versus they actually do really well with standard treatment. And so ENZARAD took these high-risk patients and randomized to ADT alone with radiation for 3 years or 2.5 years versus ADT plus enzalutamide. And what we saw is overall there in the box, it was a negative trial. I would argue the first negative trial we have seen of androgen receptor pathway inhibitors, and this was with enzalutamide, which has more New England Journal of Medicine publications than any other drug in prostate cancer history. We know the drug works. The question we're really asking is this the right patient population, not is the drug efficacious? Because the drug is efficacious, but in patients that do really well with standard of care, you're not going to be able to improve their outcomes. And so we're starting to find and identify those limits. But interestingly, if you had node-positive disease on the top, you did get a significant benefit in terms of delaying metastasis or death, suggestively improved overall survival in a small subset. And interestingly, just asking the question, did the physician plan to radiate the whole pelvis? Independent of PSA and Gleason and other factors, but just does the physician think this is bad disease and warrant whole pelvis radiation? And if the physician said yes, that's a subgroup that was large enough, they saw significant metastasis-free survival and actually a significant overall survival benefit. So clearly, again, the drugs are working. It's just finding the limits of patients that aren't going to do well with standard treatments that need treatment intensification, and likewise, those that will do very well with standard treatments. And to Fred's point, it's optimization. It's not always intensification. Often it is, but not always. There are other ongoing studies looking at this that are going to be reading out in the near future. Proteus is a surgical trial. To my knowledge, one of the only ones looking at adjuvant, neoadjuvant treatment in the surgical space, so we're eagerly awaiting those results. Atlas, very similar to ENZARAD, a larger study using apalutamide. That's going to be reading out hopefully soon. And then diazyl HiCap is a radiation trial looking at darolutamide, and again, eagerly awaiting those results. So I will turn it over to Fred.
So thanks, Stephen. That was great. So we have already a couple of questions before I jump into the panel discussion. So how would you choose Enza plus Leuprolide versus Enza monotherapy for those patients? Because we did see you didn't reach an improvement, but it looked to be almost as good as Leuprolide alone if we're looking at those long-term survivals.
Yeah, so I mean, I think it becomes, to your point in your slide, shared decision making. What is it that you value? And it's interesting, there was a study that talked to prostate cancer patients and said, what is important to you? And actually living as long as possible was like number 4 on the list. It was actually quality of life, spending time with family, other things. So in that sense, if the patient's goal is overall survival, living as long as possible, it's clear it's combination. That's the right answer. But if it's preserving sexual activity, we think vitality, we couldn't measure it with our questionnaires, but anecdotally, I think there is, then I think it brings monotherapy to the table. I would not do it in the doubling times less than 3 months. The most lethal disease really needs the most aggressive treatment. But in the 3 to 9 months, still lethal disease, but not quite as bad, I think it really brings monotherapy as an option.
Perfect. So just for some discussion in the panel, this is a 68-year-old, so the closer I get to 68, the younger I think these patients are. So my definition of old changes as I change age. He's a retired mechanic. He enjoys playing tennis. And 5 years ago, he had a radical prostatectomy with Gleason 8 disease, PT3A. He had positive margins. He was node negative. He had biochemical recurrence treated with radiation therapy, and now is presenting with a rising PSA. It's up to 3.1, and this urologist did the right thing. He did calculate PSA doubling time, and it was 6 months. So let me throw it out to our oncologist. I mean, this patient, what would you do coming in? Treat right away, or would you do a PSMA?
Yeah, 5 years ago, we would think about this patient as just biochemical recurrence. We would probably talk about restarting his hormone deprivation. Now we have this whole advent of PSMA imaging, and we are able to localize disease and accurately see to a molecular level where that disease might be. So I think someone in this setting coming into our clinics, we would absolutely do a PSMA PET. Often they're already coming into my clinic with their PSMA PETs and saying, hey, I can see it. What are we going to do about treating it? So if it's outside of the prior radiation fields, we'd probably be talking to our radiation oncologists as well, thinking about oligomet directed radiation, as well as then adding hormone deprivation, and could we add enzalutamide to this patient? I think he would fit the EMBARK criteria, and we would go from there.
So I think that's a really important, and that's what I was going to ask you.
I 100% agree, and I think we'd manage it very similar. And I think for let's say we see a little spot on the PSMA, and now we're talking metastasis-directed therapy, systemic therapy. What I would say is we now, in light of the EMBARK with the overall survival, we have level 1 evidence of an unprecedented survival advantage with ADT plus leuprolide. And there's a lot of small studies, phase 2s with radiation. Maybe we can delay hormonal therapy, combine with hormones. We can extend, progression and different things. But we don't have that OS data. So to me, it's very hard to justify MDT alone in this patient. I'm not saying you were suggesting that, but that's why I like the EMBARK regimen, because it's aggressive, which we want to do for this patient, but it's 9 months and then we stop. And then hopefully we can buy a long time off treatment, but I would do both.
No, that was the main take-home message, is that if you are going to do a PSMA, don't go after the red herring and just treat that metastatic site. This is lethal disease. Now, if his PSA doubling time was 18 months, that would be the ideal patient to maybe look for a distant met, treat, but systemic therapy is the foundation of what's going to help this patient. This is coming back to the non-metastatic CRPC high-risk population, where we had these discussions. What do we do with the 98% of patients that have something on their PSMA? It doesn't permit you to exclude the life-prolonging evidence of systemic therapy and optimizing. And I appreciate Stephen's comment, and that's what I liked the most. This was a Canadian flavor to the study of EMBARK. Stopping treatment is where we need to go. We intensify, we optimize, with the goal of maybe being able to stop therapy for much longer than we were able to do in the PR7 study, where we did intermittent versus continuous for exactly this patient population.
Yeah, it's the Juanita Cook New England Journal, so that was the basis of the intermittent, absolutely.
Great. So that's great. So you can hold on to questions, send them in virtually, and we'll try to address as many as possible. But we'll continue for this. So I have the task to try to cover in about 12 minutes navigating through the therapeutic choices for patients with metastatic hormone-sensitive prostate cancer. So, it's the good news is it's overwhelming the amount of therapeutic options we now have for metastatic hormone-sensitive disease. I mean, until 2014, we really had nothing more to do than ADT for patients who came in with metastatic disease. We had to wait for them to become metastatic castration resistant before we can give them life-prolonging options. So 2014, with the introduction of docetaxel in 2 randomized studies proving that improves survival, and then a slew of other therapeutic options up to more recently in 2024. And really, the bottom line is you can definitely do better than ADT alone. ADT alone, in my mind, and I think in most people who treat this disease, you have to justify why you're giving ADT alone. You no longer have to justify why you're doing more than ADT. That should be the de facto therapy for patients who have metastatic disease, whether it's de novo or asynchronous after having had local therapy. And whether you choose docetaxel, apalutamide, abiraterone, enzalutamide, all 4 had shown very similar improvements in overall survival. But really, the big change came when we had non-chemotherapeutic options for these patients, much easier to tolerate, much more acceptable, and many more patients could actually get therapy to improve their outcome. Now, when we saw the chemotherapy and ARPIs improved survival, the next logical thing, and I had written an editorial on this, would be to combine. Why not take 2 mechanisms of action and try to combine their efficacy in patients with metastatic disease and see if we can do even better than either one alone? And the first to report was Piece 1, mainly run out of France. And here they showed that adding abiraterone to patients getting both ADT and docetaxel improved overall survival in the high volume disease setting. Unfortunately, in the low volume disease, that wasn't as clear that we were improving outcome in those low volume patients. And then more recently, the ARASENS study was the only phase 3 study to address from the beginning the approach of a triplet regimen versus a doublet. And here the doublet, at the time we designed the trial, was ADT and docetaxel because that was the best doublet that was known to be efficacious. Latitude with abiraterone had not even been reported when the study was designed and started. But clearly adding darolutamide to ADT and docetaxel did significantly better in terms of improving overall survival compared to ADT and docetaxel alone, which was a benchmark that had to be beaten to show efficacy. Now the question of is it only the high volume patient that benefits? And every way we looked at it, and this was a subsequent publication, high volume, low volume, both benefited from the addition of darolutamide to ADT and docetaxel. And obviously the high volume are the ones that worry us the most, and these are the ones with the highest risk of dying early. But the low volume disease can be seen as a golden opportunity of maybe, I hate to use the word cure, that's a 4-letter word we rarely use in metastatic disease, but come close to maybe giving very long-term remissions. And you look at the low volume disease that got triplet compared to those that got ADT and docetaxel alone, and we were up to 92% at 4 years with no change in PSA, no PSA progression, versus only 36% in getting ADT and docetaxel. So this concept of intermittent or stopping after a certain amount of time, we're starting to now think about this in metastatic disease. And the low volume patient shouldn't be outrightly eliminated from at least discussing. And this is where the shared decision making becomes really important. More recently, ARANOTE as another ARPI without chemotherapy, because we had the ARASENS Daro with chemotherapy, but without, showed that we were able to significantly improve rPFS, which was the primary endpoint, as the 4th ARPI, and the fact that we already had 2 phase 3 studies that showed overall survival, we didn't design it for an overall survival endpoint, but it met its primary endpoint and now has been approved in almost all countries around the world for the use in doublet in patients with metastatic hormone-sensitive disease. Now, the importance of achieving an undetectable PSA. So whatever option you choose, we don't want to be obsessed with PSA, but for now, it's our best biomarker in terms of predicting what's going to happen to the patient. And the undetectable PSA is less than 0.2 that we've established for metastatic hormone-sensitive disease, because many times the prostate is still intact. There could be a little bit of PSA, but under 0.2 is the most common definition. And you look at the trials, whether it's with apalutamide, darolutamide doublet, darolutamide triplet, or enzalutamide in ARCHES, if you can get to below 0.2, you're going to do generally very well in delaying mCRPC in all of the trials. And that's a given. But what I'd like you to focus on is what happens if you don't get to below 0.2. If you don't get to below 0.2, time to mCRPC is around a year. So there's a huge difference. So obviously you tap yourself on the back, patients encouraged, got to below 0.2. But if you don't, you have to follow those patients differently. They have to be followed more closely. They are much more likely to fail early and need subsequent therapy early, because these patients are much higher risk of early death if you don't reach 0.2 with either a doublet and especially with a triplet. And you see that even though they got ADT and docetaxel, these patients become mCRPC extremely quickly if they don't reach the 0.2 level that should be used as a benchmark. Now, whether it's at 6 months or 9 months, depends on how long they were exposed to ADT prior to coming onto these studies. But clearly, that's a very important endpoint. The Libertas study allowed us to look pretty much in the real world compared to the clinical trials, that 70% of participants with apalutamide and ADT reached at 6 months an undetectable PSA level. So this is reassuring, because many times we're accused that patients in clinical trials might not represent the real world, but what we're seeing here is that it does clearly reflect what's going on in the real world. Now, the future, we don't have a crystal ball, but we're already getting a glimpse into what we can hope for in the future. So anyone who's younger in the room, who's worried that there's nothing left to do, we've got 27 clinical trials right now open in our center, so there's still a lot to do. We've got multiple phase 1 trials, as in all the other centers, and so there's still a huge amount of work to be done. And one of the interesting areas is looking for biomarkers to better define patients more likely to respond to some therapies. And here, one example is the PTEN deficient patient. That is, we know that PTEN deficient patients are at a much higher risk of having an alternative pathway to progression than patients that don't have PTEN deficient disease. And so this trial, Capitello, was just recently presented at ESMO again, basically a month ago, looking at adding the PTEN inhibitor capivasertib to abiraterone and prednisone versus abi and prednisone, which would be the standard of care for patients with MHSBC over ADT, and looking to see if we can improve radiographic progression and time to mCRPC. And here you see that both mCRPC and radiographic progression were improved by 7.5 months, which were both statistically significant. So in these patients that represent about 25% of patients with metastatic disease, might be getting a benefit. And so it's still too early for overall survival, but clearly there's something very interesting going on in how we can more personalize treatment for these patients. And that comes back to the PARP inhibitors that will be covered in a few minutes. But Amplitude also presented data in MHSBC using niraparib in patients with mutations that are metastatic hormone sensitive. And both the mutated and the BRCA mutated patient, and those are the patients who benefited the most, were the BRCA mutated patients that we know get outstanding results in the mCRPC setting. So instead of waiting for mCRPC, introducing this in patients that are destined to become mCRPC in a very short amount of time when you're metastatic, this would make perfect sense, and hopefully this will see approval very soon to be able to offer something in patients we find a BRCA mutation in. And then the most recent data that was presented at ESMO again is the use of radioligand therapy in MHSPC, and here it's the lutetium-177 617 molecule that is commonly named lutetium or Pluvicto, was tested in patients with hormone-sensitive metastatic disease. So here, and this is one of the uniqueness of the study, is that the control arm was what we consider the very best control arm possible. And this was ADT and ARPI, the choice of the investigator, plus or minus lutetium. So that control arm is pretty much the best we can offer on average around the world. And we did see an improvement in rPFS in this study, which was statistically significant. And the details of this study are going to be presented by my colleague, Dr. Tagawa, on Friday. So I encourage you to go and listen to the details of the trial. And very intriguing, and I think something that we can consider hopefully in the near future. So if we come back to some panel discussion, so this is Mario, even younger than 68, who comes in for bothersome LUTs. And with all the controversy, both with the American task force and especially the Canadian task force, that don't suggest that patients should be screened for prostate cancer, his first PSA level is 125. And he was tested because of bothersome LUTs. And biopsy showed that he had Gleason 4+5 disease. And unfortunately, on CT imaging, there was extensive bone metastases and a 1 centimeter lymph node in the retroperitoneum. So let me start with our urology colleague, because the gatekeepers are still urologists, and sometimes the life decisions are made in the urologist office. So what would you do or suggest to do in this patient?
Yeah, no, and we see these patients, unfortunately. Not frequently, fortunately, but we do occasionally see these patients. And so, I'm starting to think that there's the minimum I want to do, and then there's additional things I'm thinking about. So first off, you've done your metastatic workup, extensive bone metastasis. So he's not a candidate for metastasis-directed therapy. Presumably there's too many. So to me, the backbone of therapy would be ADT plus an RP. We can debate which RP you prefer. They all have benefits. And then the question is, what else can we add to this? Because clearly this patient's likely to be in trouble. So I'm starting to think genomic tests. Am I thinking about pulling a PARP inhibitor? And, for me, I'm often thinking the standard would be a doublet. And then what are the candidates for a triplet? And if I do a triplet, what is that X? Because it's ADT plus RT plus X. Is it chemotherapy, which is what it's been recently? Is it a PARP inhibitor? Is it a Capitello regimen, not approved, but is it PSMA? Again, not approved, but starting to think about these things. And then, to play the role of the urologist, he has bothersome LUTs. So, hopefully that will improve with hormonal therapy, but how long is that going to take? And his bothersome LUTs, he's in retention with a PVR of 700, or is it he has a little bit of nocturia and a little bit of slow stream that's going to improve? Do we need to think about some sort of channel TERP for him? We still need to play urologist and treat his urinary symptoms, but certainly this is something, in our setting, we'd very much involve the medical oncologist and to help us understand what that triplet, if we're going to do a triplet, is.
Right, so let's hear from the medical oncologist.
Yeah, no, I think this is really important because it's such a common presentation in my clinic, unfortunately. And with high volume disease, we saw the data from Arisen's, really docetaxel is quite a good standard to add. I think everyone in this setting needs to be undergoing genomic testing. We'll talk a little bit about that in the castration-resistant portion as well. But if we are getting that early genomic information, more likely to be considered for a PTEN deficiency type of regimen with papivarsertib, or with, once it's approved, or with HRR alterations, thinking about a PARP inhibitor to intensify high. And I think both are good options for selected patient populations. Lutetium, everybody's asking for Pluvicto these days. It's on all the commercials. And so, we would be talking about the right patients for lutetium once the label expands. But I think it's hard to say, well, you could use lutetium now in this space and save docetaxel for later, or you could use docetaxel now when people are fit and functional and very well, tolerate it more. I think the people in this setting tolerate docetaxel better than once they become castrate resistant. But I think sequencing either, both are life-extending options and should be offered at some point.
And I think that's really one of the key messages. The number of lines of therapy directly correlate to the survival. So whatever the sequence you decide to use, the important thing is to make sure that we get these opportunities to use these therapies in some form of sequence. Unfortunately, when we look at the data, many patients don't get more than one line of therapy, and that's really unfortunate in countries that we have options and availabilities. So basically, for now, chemotherapy should be discussed in all patients that come in with this kind of disease. I would totally agree. And let me challenge, why would we do genomic testing? What would it change in the hormone sensitive with no approvals? So why encourage the urologist to think of doing genomic testing at this stage?
Well, one, it's guideline-driven care, but subsequently, I think finding the right patients for PARP inhibitors, if not now, then using in the castration-resistant space, having that information in the back pocket is so important. If they have BRCA2, which is the most common HRR alteration in prostate cancer, talking about it with their family members and their children is all part of genetic counseling in our cancer centers. So very important to have genomic testing up front. If they have PTEN loss, the IHCs, and we're starting to think about how do we use this more broadly as the Capitello data came out and as we're about to see what the FDA says. But as that label expands, we absolutely need to know what our genomic information is early on so that we can determine other treatment options later on.
And I'll just add to that, 100% agree. And also to keep in mind, to your point, it's not necessarily actionable today. We're waiting for approvals, and I think it will be actionable soon. But when the patient progresses to MCRPC, we're certainly going to want to know that information. And with our treatments, with triplet, we're doing pretty, it could be a few years from now. The patient could move, no longer have access to the tissue. We have the tissue. It's fresh. It's very likely we'll get a signal 4 years from now. If he progresses, the tissue's older, he's moved, it's not accessible, who knows what happens, and this is our best opportunity to get that.
Exactly, and that was one of the take-home messages, that fresh tissue is much more reliable to give us the answer that we need. So do it at the time of diagnosis much more, and for the family. I mean, these are things we are responsible of, and over above that, if we know they're BRCA mutated, they need to be followed differently. We know they're going to progress to MCRPC earlier than patients who are not mutated. So there are a lot of advantages to doing this early. So with that, I'm going to hand it over to Dr. Qian Zhang to talk about a huge area of MCRPC.
Thanks, Fred, and thanks to PeerView and ZERO for having us all discuss the spectrum of disease of prostate cancer today. So we'll switch gears to castration-resistant prostate cancer, touch base on the radioligands, including radium and lutetium, which you've heard a little bit about, and then go into PARP inhibitors and some novel approaches. So it's been a dozen years now that the FDA approved radium-223, Xofigo, for metastatic castration-resistant disease based on the ALSYMCA trial. A little bit more recently, the ERA-223 trial with abiraterone and radium in metastatic castration-resistant disease unfortunately showed an increase in fracture risk. So that blue line is patients developing more fractures as they received abiraterone and radium on that trial. And so in the past year or so, we saw the results of PEACE-3, which was radium-223 plus enzalutamide versus enzalutamide alone in patients with metastatic castration-resistant prostate cancer. They had not had prior AR-targeted therapies or abiraterone, so it's a select patient population, but kudos to the French team that got this done. And the primary endpoint here was radiographic progression-free survival, which was met. And indeed, if you look at the fracture risk, when we're thinking about using these setting, radium in the castration-resistant setting, we're really needing to use bone-protecting agents. So these are zoledronic acid or denosumab in settings where we have access. But those patients with enzalutamide and radium that were treated without that bone-protecting agent were almost 4 times as likely to develop fractures over the course of this trial as patients who received enzalutamide radium with a bone-protecting agent. So really important in castration-resistant disease with bone metastases to be adding those bone-protecting agents to patients' treatments. And so in my practice, it's always a problem line, and thinking about what and when this patient received their last bone protection agent. And when we combine radium with 223 with enzalutamide in PEACE-3, we did see the improvement of that primary endpoint of radiographic progression-free survival. Hazard ratio here was 0.69. And also in the overall survival, even though with the crossing of the curves early on, this was, you're seeing a tail of the curve here with overall survival at the interim analysis. And I think further follow-up will and show even more of a difference as the trial matures. There are other trials assessing radium-223 in metastatic castration-resistant disease. The RADIANT trial is looking at radium or the second ARPI or abiraterone, and the DORA trial is adding radium to docetaxel versus docetaxel. So really important building evidence for using radium in different settings for castration-resistant disease. In our practice, we certainly think about it for patients with extensive bone disease in either the pre-chemo setting where patients are not exposed to AR-targeted therapies, or in the post-chemo setting per this label. All right, so turning gears a little bit to PSMA-targeted lutetium. We're very familiar now with PSMA lutetium ever since the VISION trial completed and showed lutetium improved treatment outcomes compared to best standard of care options. This was either the ABI or ENZA type of standard of care in the refractory disease post-chemotherapy, but in VISION, PSMA lutetium did improve overall survival and radiographic progression-free survival. And so we've had lutetium in the post-chemotherapy space now for about 3 years and ongoing in our practices. Many patients are having benefit from PSMA lutetium. More recently, we saw the PSMA-4 trial readout. This was in pre-chemotherapy, so metastatic castration-resistant disease, but patients who had received prior AR-targeted therapy, but taxane naive, receiving either PSMA lutetium or undergoing an AR-targeted therapy change to either abiraterone or enzalutamide, whichever they had not received prior. And we saw a radiographic progression-free survival. Of note, the trial did allow crossover, so we haven't seen the overall survival endpoint quite yet, but of note, it was not worse. And so there was a little bit of a delay in us seeing that expanded indication, but in March of this year, we did see the expanded indication of PSMA lutetium to allow lutetium for metastatic castration-resistant disease prior to taxane-based chemotherapy. So now we're able to think about PSMA lutetium even for patients with earlier metastatic castration-resistant disease who have not received taxane-based chemotherapy. It does come with side effects, and so the most bothersome for my patients are the dry mouth, and there's PSMA uptake in the salivary gland, so it's quite an on-target effect, but that xerostomia is pretty bothersome to folks. When we look at what stops treatment and what we might dose delay or stop completely, it's that myelosuppression. So it's really important to check the CBCs before each 6-week cycle of lutetium, and the GI effects, fatigue, and renal dysfunction, back pain. These are all things that we should keep in mind as we're giving lutetium in our practices. This is a very busy slide of ASCO guideline, but just reminding everybody that it's really important to for our patients to undergo genomic and somatic testing in metastatic prostate cancer, and then also to think about germline testing as well, because if they do have something germline, that will affect their children and grandchildren, and very important when we're seeing folks with metastatic prostate cancer to think about this. And in fact, when we do find that homologous recombination defect, we're able to use PARP inhibitors in our practice. And so monotherapy, olaparib and rucaparib, were both approved from the PROfound and TRITON2 trials, respectively. But as we're looking at real-world data, retrospective Flatiron data, that rate of NGS testing is actually quite low. Only about a third of patients over the last 10 years or so have actually their NGS testing in these databases. So it's important, and I hope as we're getting more mature data after 2022, that will have further uptake as we have more therapeutic options available for these patients, and as the guidelines have been updated to mandate genomic testing. There is some rationale for combining treatments if one works and the other works and they're not too toxic. Med-oncs like to combine them, but there is some biologic rationale for combining an AR-targeted therapy with a PARP inhibitor. And so now there are 3 PARP inhibitor combination trials that have read out: the PROPEL trial with olaparib and abiraterone, MAGNITUDE with niraparib and abiraterone, and TALAPRO-2 with talazoparib and enzalutamide. And all 3 of these have now been approved and are able to be used in our practices. This is a little bit of a busier slide, but I like to highlight that the patient populations in these 3 trials were somewhat different. So in PROPEL, they were all unselected metastatic castration-resistant prostate cancer treated with olaparib with Abi versus abiraterone alone. In MAGNITUDE, they were very careful to select the patient population. So in cohort 1, they were all patients with homologous recombination defects, so HR positive disease. Cohort 2 had HR negative disease, and so you really see that difference between the 2 cohorts. And then TALAPRO-2 initially allowed that unselected patient population and then expanded to enrich for the patients with HR alterations, the patients more likely to respond to a PARP inhibitor. And so as we're seeing unselected patient populations, radiographic progression-free survival did improve across populations in PROPEL and in TALAPRO-2, just all comers. But if you look specifically at BRCA1 and BRCA2 altered subgroups for PROPEL and MAGNITUDE, these effects are dramatically different. And so the patients who are most likely to benefit from these combination strategies, the PARP inhibitor added to their abiraterone enzalutamide backbone, are the patients who have BRCA alterations. There are some common adverse events across these PARP inhibitors. It is a class effect that they do drive cytopenias and also some non-hematologic nausea, diarrhea, asthenia. Very, very rare, but we have seen case reportable AML, MDS, and pneumonitis. So things to keep in mind, but that CBC is going to be our friend as we're monitoring patients on PARP inhibitors. I often see folks back 2 to 3 weeks after they start any of these PARP inhibitors. So current takeaways: many new treatments are available for metastatic castration-resistant prostate cancer. It is becoming a chronic disease, I think, in our clinics, which is wonderful to see. And I think it's important that we're thinking about sequencing our treatments and allowing those life-extending therapies for our patients. There are challenges to using some lutetium and thinking about which setting to using it. And so that's a time for shared decision-making. And then it's important to find that genomic, do the genomic testing so that we can find the right patients for PARP inhibitors going forward. And there is some disease heterogeneity as treatment resistance occurs, and I do think it's important that we're thinking about those resistance mechanisms and target those as things go forward. And then we'll move forward to the future for castration-resistant disease. There are a number of phase 1s in our clinics. Dr. Saad has 27 phase 1s available, and so it's really exciting, the newer technologies as we're able to be smarter, hopefully, than castration-resistant disease. And so we're highlighting a few classes of these agents now, but there's first-in-class bispecific T-cell engager, pasritamig. We saw some of that for phase 1 data at ASCO this year. It's coming out in 2 phase 3 trials, Passenger and Compass, and so more to come from this whole class of T-cell engaging effects. There is also a target called B7H3 that's highly expressed on our metastatic castration-resistant prostate cancer cells. There's 2 agents currently in trials. Duality Bio 1311 agent was also presented at ASCO this year, and there's a big phase 3 with IDXD, IDA Prostate 1 that is already launched. It's a global trial compared with docetaxel. And so I think this class of antibody drug conjugates coming into prostate cancer is really exciting for the field. There's some novel oral therapies as well. The EZH2 inhibition with mevrometostat, MEVPRO-1 and MEVPRO-2 are both phase 3 trials in the castration-resistant setting. Those are ongoing already. And then the ODM-208 is CYP11A1 inhibition, and then there are some AR degraders. So if AR is accumulating and amplified, could we degrade it at a protein level? So both PROTAC and the AR-RIPTAC agents are showing some really promising data there too. And this is the last plug for ZERO, and thank you to ZERO for sponsoring and helping us with this program today. There's a link there for the clinical trial finder platform that ZERO provides for all patients. So I think it's really important as we have all these new therapeutics available that our patients are able to find the sites that are able to access the newer therapies that are coming through. So certainly look at that website to find the right trials. And with that, I'll turn it back over to Fred.
That was amazing. I mean, that is just a glimpse of what's going on. So if anybody is not overwhelmed, I think you're in the wrong room, because this is amazing watching this field explode, how we're going towards more and more personalized approaches. It's really fascinating. And what's most important is this is really giving us some optimism for our patients, because MCRPC is uniformly lethal disease, right? I mean, that's why we die of prostate cancer. As long as we're not MCRPC, you simply don't die of prostate cancer, you die with prostate cancer. So we really have to work pre-MCRPC and try to avoid even reaching that state. But it's very, very important that we understand that state and do what we can, because the options are limited and the time we have is limited. So making the right choice at the right time is critical, because our old ways of doing things, trying something, waiting 3 to 6 months, can be the life of the patient that we just wasted by not choosing the right option at the right time. So there was a question here of what are you expecting in terms of the outcomes of some of these ongoing. What's exciting you the most right now that's going on? I mean, you showed us that last slide is worth a fortune in.
Well, I think the companies are also investing a fortune in those trials, but the exciting mechanisms that we're seeing and new targets. I think for a while we've depended on hormonal treatments and AR pathway, but also thinking about other drivers of prostate cancer progression. So I'm really excited about the B7H3 story because it is so prevalent on prostate cancers. There's the novel, T-cell engagers if prostate cancer is cold, and we've seen so many checkpoint inhibitors, unfortunately fail in this space. Could we get the T-cells to the party and actually allow more immune effect for prostate cancer? So those are probably the two that I'm most excited about, and there are some CAR-Ts also that we didn't even show on that slide, but all really exciting, and I think it's really going to be how can we find the right patient population, really enriching that population for the patients who are most likely to respond to each of those strategies.
That's great. And how many, I assume this is the SUO, so the most are the urologists. So how many are totally confused? And those that are preparing their exams, how many are totally discouraged? Because all of this didn't exist at the time that we studied, right? I mean, Stephen is quite a bit younger, and even then, all of this wasn't around. So I don't think you need to be discouraged, but this is the kind of language that we need to get involved in as urologists if we want to keep a leadership role, working with our medical oncologists, working with our radiation oncologists. Nuclear medicine now is part of our tumor boards. This is really, really becoming an opportunity for true multidisciplinary care. Our pharmacists, all these drug-drug interactions, it's fascinating. So I think that's been great. We just wanted to end on maybe the complexity, and this is something that I put together because I lead the guidelines in Canada. So what is first-line MCRPC? It's becoming extremely complicated, and it's only going to get even more complicated in the future. But for now, if you get a patient who's first-line MCRPC, that means nothing anymore. You have to know what they got prior to becoming MCRPC, because the way you're going to treat them for first-line MCRPC is totally dependent on what they got before becoming MCRPC. Because obviously, the historical pathway was ADT, and then you become MCRPC. And we had a slew of options. But now, you have to know, is this patient post-ARPI? Which I hope more and more patients are going to be ARPI exposed prior to becoming MCRPC. And if they got it for MHSPC, they probably continued until failure. But then there might be some patients that got it for a short amount of time for localized disease, and then 2 years later, they're MCRPC. We didn't even find a name for those patients yet. So those are ARPI exposed rather than ARPI resistant. And so we have to deal with all of these, but the very minimum is, are they post-ARPI? Are they post-ARPI plus docetaxel? In that scenario, they're automatically eligible for PSMA lutetium. They've already failed docetaxel, even if it was 2 years before, because they got it with an ARPI. You don't need to re-expose them to a taxane to get them to be eligible for a drug like lutetium. For patients who are ARPI exposed, you have to know, are they mutated or not mutated? The way you're going to treat them in first-line MCRPC is going to be very different. If they're ADT exposed, are they mutated or not? Because those would dictate whether they can get a combination therapy. So this is just some of the complexities of putting guidelines together, is you really have to try to understand who you're treating and what they got in the past to help you decide what's the most appropriate going forward. And I just declined all the second line and all the rest, but radium, all these others have to be put in.
Fred, if I could chime in for a second. So I agree. I think the take home is prostate cancer has gotten a lot more complex. Since the 1940s, we've done orchiectomies, and then ADT came along. And that was simple. That's all we had. Maybe a little Casodex here and there, but that was it. And as hopefully you have heard over the last hour, this is a very complex disease. And we now can do ADT much better than we can in the past. But we also need to recognize when ADT alone is not good enough. We need a triplet. They've failed ADT plus an RP. And I think the take-home message to me, to fellow urologists, as a urologist, is this is complex, but it is learnable. But if you understand and recognize this is complex, and you don't feel you have the skill set or the infrastructure to deal with specialty pharmacies and AEs and other things, even if you have the knowledge, make sure that patient gets in the hands of someone who does. And that could be another urologist, it could be a medical oncologist, does not matter. We just got to make sure our patients are getting optimized care. And again, hopefully for those who are interested in doing this, you've learned a little bit from this. But to me, the take home is it's a lot more complex than just ADT, and then when you fail, then send it to someone else.
Yeah,
it's a different world.
Yeah, and we need to stay involved in. One of the questions, and you brought this up at the end, is how do you get these shared? It's nice to say shared decision making, but how do you actually communicate and get patients empowered enough to actually contribute to making these decisions that are not, always clear, whether you dose docetaxel the triplet, yes or no. It has to be a shared decision.
Right, and I always think about what are the standard of care options and try to present all of those. And then, in our clinics, in our bigger centers, we have a number of trials now. So then we say, well, then this is a trial that I think you might be eligible for and you might be a good candidate. And so that's a lot of information, and it takes a lot of time to go through. And I think that's in part why advocacy groups and patient groups linking patients together of here's somebody who has done this, and he might be able to talk to you about it. That brings forward that a very personal approach for a patient facing the same decision. So the role of patient advocacy is great, but it does take a long conversation in our clinics of what are the standard of care options, and then let's make a decision in 2 weeks. Give us a week and have you think about it. In the hormone sensitive space, I stage my treatments. When we start hormone deprivation, and I say, well, here's all the other things that we will intensify likely, and I'll give you all the reading material. Come back in a month once you've adjusted to the hormone deprivation. We'll talk about what other options. Gives you a chance to do genomic testing in that time as well. So it's a number of choices, very complex disease, but great options for our patients now.
So unfortunately, the hour is already up. We could have stayed here for another couple of hours and discussing more and more. Hopefully it was useful, and all of these things are important, and I really do encourage you to think of clinical trials, as was mentioned. We're still working on that, and try to get help. We can't do this alone. We have nurses that are dedicated to help patients progress through this, and I just wish you a very enlightening SUO and a great time here in Phoenix. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, ZERO Prostate Cancer. This activity is supported by independent educational grants from Astellas and Pfizer Incorporated, AstraZeneca, Bayer HealthCare Pharmaceuticals Incorporated, Johnson & Johnson, and Novartis Pharmaceuticals Corporation.